Yeah, great. So it's exactly 4 p.m. IST, and let me welcome everybody to this webinar today with an exciting topic of designing the smiles for full arch implant rehabilitation. And I think we have an excellent panel here today with Professor Adam Nulty and Dr. Quintus, both from the IDDA UK. Welcome to you guys. Thank you for accepting our invitation here to be on our webinar. Before we
Hi,
start, let
Bezin.
Hi,
Hi,
Berzin.
hi
Thank you.
guys. Yeah. So let me just give a brief introduction to you guys. Professor Adam Nulty is a distinguished figure in the field of digital dentistry, well known, of course. He's the founder member of the International, or in fact, the founder of the International Digital Dental Academy, and the
Co-founder.
creator and the creator of ScanLadder, an award-winning patented scanning system that has transformed full arch digital implant workflows. With profound expertise in digital implantology and CAD/CAM dentistry, Professor Nulty has dedicated his career to advancing clinical protocols through further qualification, a PhD in guided edentulous implant placements, and extensive research with the same. His work focuses on enhancing accuracy, efficiency, and patient outcomes through integration of digital technology. And that's where ScanLadder is on top of the notch right now with the horizontal scan therapy that we have. Highly regarded for his dynamic and engaging teaching style, he has trained thousands of dental professionals worldwide and shaping the global adoption of digital dental solutions. His peer-reviewed publications and key innovations have made lasting contribution to the field of aesthetics, restorative, and implant dentistry. Professor Nulty holds a multiple degree and fellowships in dentistry and has received numerous accolades for his clinical and academic excellence. As a keynote speaker at international conferences, he inspires profession by promoting a seamless fusion of healthcare and technology. And regarding Quintus Wantondo is a multi-award winning clinical and distinguished graduate from the University in Cape Province, South Africa. Quintus's enthusiasm in technology has again driven him to integrate the latest advancements into his practice. He is particularly passionate about creating lifelike restorations chairside, which you will see today in his presentation, utilizing cutting-edge softwares like Exocad, the Dentsply Sirona InLab, and Serec. He meticulously finishes the restorations in-house and has a keen focus on surface texture, detailed processes of staining, glazing, and ensuring with restorations perfectly mimic the natural teeth. In addition to his clinical achievements, Quintus is an associate or an assistant professor, rather, sorry, of digital dentistry for the College of Medicine and Dentistry with the Ulster University. And he currently holds the position of a vice president at the IDDA, contributing significantly to the field of digital dentistry through his expertise and leadership. Welcome you both. And I think, Adam, do you start with the presentation first?
Not really, actually. Today is going to be Quintus for the first half.
Yeah. So thanks, Berzin. That was quite a lot.
Yeah,
We
thank you,
don't,
Bezin.
yeah, thanks for the invitation and thanks for everybody attending. For both of Adam and me, we silently have this little competition going about who can create the nicest restoration. So we always share our photos with each other, and then we sort of try and see which one looks the best. And it's a healthy competition, and it helps us to actually be very critical about what we do and how we achieve the results that we achieve. And in the digital dentistry, it's a completely different ball game to just sending your lab work to a lab and let them worry about all of the technical side of it. But the more you learn and the more precise you want to be, the more you sort of get into it and try and do the things more yourself. So that's where we try and be excellent in what we do and try and get the best results for our patients. So this is where we're going to start today with the designing the smile. So Adam is in control of the presentation. We are about 50 miles apart at the moment. So I'll just tell him to, okay, go to the next slide and then we can
Yep.
get on to the next thing.
I think if I might add, Q, the important thing from today's lecture is the combination of full arch rehabilitation principles in terms of facial analysis that really applies for anything from veneers all the way through to, like I said, full arch rehabilitation, whether that be veneers, crowns, or all on X with implants. The same principles apply, and actually if you use those restorative principles well, it doesn't only help you with the all on X, but it helps you with any case to be able to plan the appropriate lip line. And people kind of separate the lip line out when they're thinking about, the restoration side of things versus all on X in terms of FP1, FP3, but really they're linked and planning the whole case from the start according to the face is really important for any type of restoration, whether it be even just a couple of veneers at the front of the mouth. So the first half of the lecture is Quintus's lectures. Quintus's slides based on some of his lectures where he analyzes the face, shows you how he goes about that in terms of the approach to seeing the full face and not just the teeth on their own, and how that then links in with All on X, the deficiencies in scanning and the problems that we have, and where ScanLadder comes in. We'll talk about in the latter half later on for myself.
Okay, great. Thanks, Adam. Yeah, if you can go on to the next slide. We've got a little video here of different smiles that we've done over the years, and the music is not really working very well, Adam. Maybe just switch that off.
I'm going to skip past that, Kim.
Yeah, so the thing is with any sort of the Zoom things, it doesn't always work very well with video streaming, but um, we'll skip most of the videos, but there's not many of them. So for when we look at a smile and when we look at a patient's face, the most important thing that I look for and what I've learned over the years is that the face and most people's faces are not symmetrical. And the biggest problem you have is that in a face that's not completely symmetrical, and this is normal biology, it's very difficult to correct things that you don't look for. Now, the way that you normally see you've made a mess up is when you get to the end result and either the midline is out or the midline is canted or the midline and the whole design looks good, but then when the patient holds their head in a normal position, it can look canted. Now, I've made the mistake many times of designing a smile to what I think is the actual correct vertical and horizontal dimensions, but then it ends up as a completely canted smile when the patient is walking around or just holding the head in the right position. So over the years, I've learned to look at a few things here. So the things that I look at is the interpupillary line, commissures of the mouth, the incisal edge line, and those are all good, but the most important thing is the vertical line. Now, I don't say the midline of the face. I'm talking about the actual vertical line that the patient's face is being held at. Adam, go to the next slide, please. So if you compare this photo to the previous one, in this one we've corrected the vertical. So in the previous one, the patient's midline was slightly canted. And if we designed and we kept the design the same, the whole smile would have been designed completely wrong and it would be a canted look when the patient is smiling or holding the head. So when we look at these things, the vertical line is the most important line, and we start with that. Adam, next slide, please. The other thing that is also really important is for me is the lower lip line, and we'll get to that a little bit later on in what we discussed. But you have to keep that in mind, but we'll get to that a bit later. The other one is the incisal edge line. Now, the incisal edge line is basically just the flat part of the two central incisors, and we want to keep this line at a 90-degree angle to our vertical line. Adam, just keep next slide, please. So if you look at this, shows the vertical line of the patient and the midline. And the midline is, if we make it in the midline of the face, that's great. The vertical line is slightly canted, and that is what we've analyzed from looking at the photo. So next slide, please. And then when we've corrected it, we can see the vertical line and the midline are now parallel to each other. Now, everybody has probably seen photos of Tom Cruise and you know how far out his midline is, and it just shows that when you look at the midline does not have to be exactly in the midline of the face. So your midline of your design doesn't necessarily have to be in the midline of the face, but we need to make sure that our vertical line is parallel to that line. Next slide, please, Adam. And we also then get to design our incisal edge line at a 90-degree to our vertical line. So once we've established the vertical line, we can then do the incisal edge position. Okay, next slide, please. Now in this slide as well, the midline and the vertical line is completely in separate places, and this patient doesn't have a midline that's completely in the middle of his face. But when we design the smile and it looks like that vertical line is correct, your eyes do not catch it that there's something wrong with this smile. It still looks correct. And in some cases, you can move that. You can do that with orthodontics, or in full arch rehabilitations, this is much easier to solve in the sense that we are going to design a full arch. So we don't need to worry so much about where that midline and vertical line is, but we need to make sure that that vertical line is in the vertical of the face. Next slide, please, Adam. So you can see in this case, vertical line and the midline is in parallel, but they are in different places. And because these are natural teeth, we're not going to extract them, but we can then fix them and make sure that the smile looks correct when the patient is smiling, and that when you look at it, it doesn't look like there's something off. Next slide, please, Adam. So yeah, so what we conclude from that is that the vertical line set up in the design software will determine our horizontal aspects of our designs. And that is always, we start off with the two incisal edges and then we move further back from there. And that has to be at a 90-degree angle to our vertical line. Okay, next, Adam. So in the design now that we have is we have a lot of face scanners available, and face scanning is really a helpful way of helping us to design all of these, especially in full arch cases, to make sure that we know where our positioning of the teeth are or needs to be, and also the progression from the front to the back and from lateral views. Now, the face scanning is not 100% accurate, but it is a lot easier to design than just using 2D photos. So a big problem with just normal photography is that sometimes the patients don't look at the camera correctly, or your setup isn't correct to take the correct photos. So it is easy to make angular mistakes from there. But with 3D face scanning, we can bring it into the design software and we can overlay our scans, we can overlay our mock-ups, and we can then create something that we know has got a really high probability of being 100% correct when the patient is smiling or holding their head in the right position. So when you do the face scans and when you do the photos as well, look at how the patient holds their head as well. Sometimes patients don't hold their head completely horizontally. Sometimes the eyes are not at the same level, and then they tilt their head slightly to have the eyes being basically horizontal because the brain compensates for that. That means that the face is slightly canted, and we have to design to those positions because that is how the patient will hold their heads. And it's easy for us to look at it and say, okay, in this position it is correct, but then when it comes to real life, it is not 100% correct. And we want to eliminate those errors as much as possible. And in Exocad, it's very nice to have these guidelines, and you see how relevant those lines become when we have when we're trying to design our prosthesis. So no matter if it is crowns, veneers, full arch cases, all of it stays the same in the workflow. Okay, next slide, please, Anna. So lip line, this is very important, and you will see in normal literature, a lot of it is focused on the actual upper lip, and it is important because it does. If a patient has got obviously a wide, broad smile, we've got a design to that. If a patient has got very thin lips, that normally makes it more difficult to make a nice aesthetic looking design, but all of those things are really important. But for me personally, Adam, if you go to the next slide, the lower lip line is actually, for me, more important than the upper lip line. So the upper lip line is going to determine how much gum the patient shows. So if we have to do FP1 or FP3 or whatever design we need to do. But the lower lip line is going to basically give us the curve that we need to design to. Now, if you look at this case, patient has got actually a very nice wide smile. So we know, okay, we've got to do the wide smile, but we need to look at the lower lip to know how curved that smile needs to be. And then we go to the next slide. So the smile progression for me needs to follow the lower lip shape. So if the patient has got a very curved lower lip like this patient has, I'm going to tilt my design at the back, in the curve of Wilson, I'm going to tilt that more up. So it's going to be a more pronounced one than a patient that has got a flat or a less curved lower lip. Next slide, please, Adam. And this is the design that we've made for this patient. So you can see we followed that lower lip shape, and it really makes it go from a nice case to a wow case. So the patient, when they smile, they got complete confidence in their smile, and they're not worried psychologically about little small things that maybe the angles are wrong or anything like that. Next one, Adam. So even from lateral views, it's important that we follow that curve. And that's the reason why I've put these photos in, is that you can see the shape of that lower lip is following, or the design is following the shape of that lower lip, even on the lateral views. Next photo, Adam. On both sides, we've done the same. Next one. Now, in the UK, we have a problem where we get what do they call it, Adam? Trout bouts.
Turkey teeth.
Yeah, not
No.
just turkey teeth, but we've got all of the fully full lips that patients have had lip fillers on, and in this patient, you can see there are nodules from the actual fillers that haven't been done properly. So when you have these kind of things, it also puts out your design, because you've got a fake lip line that is influenced by these nodules. So in these cases, what I do is I just basically draw those lines like I did, and I just follow the average line for the design so that I don't get too influenced by the nodules in the lip.
I think it's easy, if you don't mind me interjecting here, Quintus, you can see from this picture how much I always find, no matter what you do in terms of making teeth look natural, and this is, I think, why this sort of look, they go for I know the colloquial term turkey teeth, but more, tic-tac teeth, big, bright, white, straight teeth. They like that because when you've got more natural teeth, they look wider when the lips change shape. So
Mhm.
if you look at the upper lip there, the nodules have dropped the lip curve on the
Yeah,
sides,
yeah,
and they've increased the angle of the lower lip. So the actual teeth look different than the curve that probably would have been the case if the teeth lips would have been more natural on the lower there.
yeah.
So, if the lower lip there wouldn't have had so much filler on each side, that curve would have followed the path of those teeth a little bit more accurately.
Mm. Yeah, exactly. So I think for me, like I said, for me, I would draw an average of what I think the lip should be, and then design to that. Um, but it is difficult, and it throws things out quite a bit. And instead of being um, completely natural, we have to try and match the fakeness in there. But it is what it is. Our patients are doing these things. We don't have a choice. We've got to just go and deal with what we have and what we are presented with to get the best results for that patient. Next one, please, Adam. So digital smile analysis, it is basically, it's just using software to digitally analyze the smile and the face. Adam, you can go to the next one. So we use for this, I mostly use Smile Designer Pro. I don't use it so much anymore. I've more gone into Smile Cloud, but Smile Designer Pro is a very, very useful tool to help us to analyze the smile and to see what we need to do, especially on where the positioning of the incisors need to be. It's really good at determining the midline and the vertical line of the face, and we can design from there, but it's still in a 2D format. Whereas now with, for example, Smile Cloud, we can upload the 3D face scans and we can upload the intraoral scans, and you can design it much easier from there. But it is much more involved, and once you or to do the final designs, you've got to pay for the exports and things like that. As whereas Smile Designer Pro is a quick 5 minute setup, and you don't have to um, have any exports or anything from there. It's just a good way to see how that smile needs to look. But it doesn't completely bridge the gap between 2D and 3D, where Smile Cloud and Exocad are now doing those things. So yeah, we can quickly see how quick that is, and we can use the same libraries that the outlines of these teeth have in Exocad. So from Anterioris, you can buy their libraries and you can put it into Exo, and then you can design your smile with the same libraries as what you've used here for the 2D mockup. So it is a 2D, 3D system, but it's not completely 3D. It is more just to quickly show a patient what can be done, and also for yourself to analyze and to see where things need to be done, and the facial symmetry and those kind of things. But it is 2D. Next one, Adam. And then this is now older form version of Exocad, but in Exocad, this is what they came up with initially to try and bridge the gap between 2D and 3D. So where we designed in 2D and 3D at the same time. So you can put your positioning on the photo, and as you are changing your design and using different libraries, it comes up on the photo at the same time. It was helpful at the time. I think there are much better systems available for us now, including 3D face scans and things that we didn't have 4 or 5 years ago when we started with all of these things. So it is helpful, but I think a 3D face scan and mock-ups now are more predictable after we've done, for example, a 2D mock-up in Smile Designer Pro just to analyze the face. Okay, Adam, next one, please. And then this is that case I was showing you earlier. This is where we started. So the patient had Invisalign to align the teeth, and then she had edge bonding done. And in the end, she wanted something much nicer. So this was the pre-op. And next one, Adam. And this was directly after cementation. So we did basically from the 5 to the 5. So I call this sort of the what's it 3-4-3 principle. So we do veneers on from the canines backwards, and we do crowns on the front teeth. So in this case, we had to do it because she had some interproximal decay, um, but very thin, like 300-400 micron crowns, and 300-400 micron veneers, to get the result for this patient. And this is all done in-house on the same day. So we design it, we mill it, finish it by hand, and then do the cementation. And this is how it looked like directly after cementation. And the next one, Adam. And this is 2 weeks later. You can see how nicely the gum has filled up all of those interproximal areas. And a very important thing is that we keep our contacts interproximally very long and straight, straight as long as possible. So the longer your contact, I can't remember the research now, but I saw it the other day again, an article about um, the the papille will grow into better grow into the interproximal area if your contacts are longer and flatter in between the teeth. So this is for this patient was a really nice result. So yeah, next one, Adam. And then we can see from the lateral views there, now everything is nice and it just looks like real teeth. So when the patient is smiling, nobody will go, okay, those are fake. We want it to look like the patient hasn't had anything done, but we want to make it look as nice as possible. Okay, next one, Adam. Yeah, so now it's Adam's turn to talk about the scanning and the more of the technical bits behind getting the smiles designed for full arch cases.
So one of the nice things, thank you, Quintus. I don't, and obviously this is a pretty quick lecture really on these things, and me and Quintus can give you hours of this. And if you want to learn more, then obviously speak to Berzin. He's running the MSc. So in terms of the transition from planning the face with any type of rehabilitation restoratively from a crown approach all the way through to implants. We need to be able to understand the smile first. We need to understand the end point first. And obviously, these days with AI and, like as Quintus was saying, some of the tools of whatever type of 3D face scanner you can use, whether that's on your phone or, through some of the 3D face scanners that are actual physical, components you can get. We're giving everything to the lab to be able to make sure that we're planning everything right at the start. Designing the smile first is super important because we need to know where we're going to place the implants, and we need to know where those implants are going to affect what we're going to do in terms of the guided surgery, the restoration, the screw channels, and also where this tissue is going to sit, whether the approach we're going to do with the lip line is going to be an FP1 or an FP3. And again, that's an entirely different lecture on its own. But briefly, if we've got the face and the lip line, my personal preference is to go down the road of an FP1, maintain the gingival architecture and keep it natural. These days, with the technology we have, we can, use, titanium frameworks and either uh, reinforced PMMA or zirconia sleeves on the titanium frameworks that, like an eye bar that would still be aesthetic in an FP1, but also strong enough to withstand the forces that we're going to experience with full arch. And again, a totally separate lecture. We should come back and do each of these with you, Berzin, but the actual forces involved that, Chris can talk to you about with a full arch in terms of the pressures because of the lack of proprioception. This all needs to be planned from the start very carefully. If you don't plan the face and the smile at the beginning, then all of the errors that you'll accumulate during the restorative process will add up to prosthesis failure, prosthesis fractures, and not only obviously the failure of the aesthetic that we're planning ahead. So, in order of importance, there, what I've talked about are the different data sets. In terms of, we start from the face, we do the digital smile design, then we use the provisional. I like to refer to that provisional as an all-round verification rather than just a verification jig that we used to use in terms of picking up the position of the multi-units and then verifying that in the lab, simply because we can do more than just that one thing. But we need to be careful, obviously, with these different data sets that we align them with one coordinate system. And so one of the main aims of what I've done with ScanLadder is given you the ability to really be able to capture data sets and align them better, not just capture one data set accurately, but to accurately combine those. And we'll talk about this a little bit more. One thing to also note as well, a big thank you to, we've got a few dozen cases that I'll show throughout the next few slides that are from ScanLadder users from all around the world. So like this one that's just played there, there's some fantastic cases that if you want to see more of them, go to the Instagram ScanLadder and you'll be able to see them. They're literally on like a daily basis. We've got the most all on X users of any system now by far. There's like nearly 3,000 users. So literally more than once a day on some days, but we've got a case from someone all around the world and some really beautiful results. So thank you to all the users that we've got here and the students we've got that have provided some of these cases. So perfect surgeries can still produce non-passive bridges. Now, what do I mean by that? Well, a really nice meta-analysis that was done by Mata Revere-Leon and a few others looked at the actual accuracy of photogrammetry across the board from different studies. And the reality of photogrammetry, everybody likes to say, oh, photogrammetry, gold standard, it's, 5 micron accuracy because they've been told that by somebody. Most likely they've been told that by a manufacturer. The reality of everything that is, the mouth is a complex piece of a dynamic changing data provision that every single stage can lead to slight discrepancies. 1 micron doesn't seem like a lot until you add that to the next 10 microns and you add that to the next 10 microns until you end up with deviations that by the end of the restoration mean that you could end up with a non-passive bridge. And so the reality of all of these instruments, we need to understand where the errors are, and we need to take into account where the possible errors can come in the accumulation of the data sets so that the end result can still be passive. And we need to understand what can go wrong in terms of passivity so that it's not just blamed on one thing or another. And I don't say that as an excuse mechanism for ScanLadder because ScanLadder is in itself probably statistically exactly the same as this with photogrammetry. It's more the fact that there are different levels of accuracy that can be gained from the different components of the restorative workflow. So from the surgery itself, the actual healing of implants can move. So over the first few months, the pressures on those implants and the healing of the implants, if the patient has a temporary restoration that's placed over the top of them, linked to them, or doesn't have a restoration that's placed, there can be a maturation in the bone that is healed around those implants, and very slight changes can appear. So, again, excellent users like Ashtonhofer and his level 3 CAD XCAD designer in Canada. He always advises everybody, even if the initial recording, whichever method you use, in the initial recording of the implant position, when you do the initial provisional, always retake your implant scans later on. But that adds a solution to, and also adds a problem. And when we're talking about 3D facial analysis, the reason why I say this slide is because that also brings in the issue of we like to use the end result at the beginning. And if we're retaking data at different points, we need to be able to use all of that previous data within that data set that we've re-recorded. But obviously, again, error can creep in the combination of that data. So making life easy in terms of having points within the data sets to be able to combine the data makes everybody's life easier. Nevertheless, there are ways around it, and also there are issues with all of these different things. The biggest thing that we're trying to get away from, and in the whole point of ScanLadder in the first place, is because conventional scan bodies are locally clear, but globally, we don't know if it'll record it accurately enough. There can be deviations from the recording of the implant solution that end up where we just try and minimize this. My mouse has somehow disappeared. There we go. So if there's drift during the accumulation of the scan frames, we won't see that until we try it in. And the reason why is because if for those of you who haven't seen any of the actual data on ScanLadder, on photogrammetry, or any of these similar systems, is because the individual capture of frames during the scanning process, and the whole reason why all of this started with All-on-X is because repeated geometry causes a problem for the scanner algorithm to add that data together. So if we've got flat pieces of paper, square puzzle pieces, it's very difficult for the scanner algorithm to understand how those link together. Geometry is the key to all of this. And so we're trying to avoid cumulative stitching drift as the scanner scans a full arch where there is isolated pieces that are the same throughout the global picture. Because the scanner then will say, well, should this scan be here? Should this scan be here? And you don't see it as the user, but the scanner doesn't think the same as we do. And the algorithm is just trying to do the best job it can. So photogrammetry solved the position capture, but it added the issue of cost and also the dedicated hardware cost and calibration issue. But more importantly, in terms of the facial analysis and planning that we had at the beginning, one thing to keep in mind with photogrammetry, outside of the actual real world error of it, even if that's perfect, it also creates the issue of it's identifying the position of the implant multi-units. Even if that was perfect, like I said, it still creates the issue of combining that with the soft tissue data set. The registration between those different workflows and the workflow of soft tissue, whether you capture that through an analog way and transfer it to the lab, or if you capture it through an individual intraoral scan, it doesn't really matter. Those two data sets, when they combine, they won't combine perfectly because they're from two different methods of capture. And so we need some common piece between those data sets to be able to allow you to be able to plan the face, which has the soft tissue in it, have the implant position, and accurately bring that into the picture. And so this is why people have moved away from photogrammetry, not because it's not accurate. It is very accurate. It's obviously still the gold standard, but it adds another layer of complexity, obviously, as well as the cost. So the geometry idea of ScanLadder is that it's something which some people miss when they're looking at other all-on-X systems which have come along after ScanLadder, where the idea of centralization they've copied and had objects that are seen in the center, and a non-clinician, someone who hasn't invented it, doesn't understand it, might think, oh, well, that's the key to it. It's not the key to it. Geometry is the key. But they can't copy that because of the patents. But that's aside. For the purposes of the lecture, the idea of centralization is to bring the number of frames to capture the position of the implants to a minimum. And so if we can get everything to the center, that's great. But sometimes we can't. And so there are other aspects of what I've created with the implant scan bodies that let you scan not only centralized, but also the ability to capture in different circumstances. And there are also common features. And there are reasons for both of those. So when we scan, we need to have the ability to be able to place according to the patient's needs at that time. And so if we can centralize, great, we're minimizing the number of frames. But if we can't centralize, if there's a big tongue in the way, if there's, not just tongue space, but managing divergent angles, big wide spacing that we can't then get to centralize, we're still leaving big gaps. So we need to be able to then have another method. And any other case or any other system that only relies on centralization then fails completely, because if you can't centralize, you've still got the same problem that we had initially with the flat featureless surface of the edentulous areas, which brings in the error. And so what the idea of this is that the geometry and the notches that are individual, the shapes that are individual, the size of the holes that are milled out on the surface of those titanium scan bodies means that those scan bodies can be positioned not only centrally, but positioned around the arch if you need them to. Overlapped around the arch doesn't matter as long as it's minimizing the gaps. The main aim of any implant recording from this should be, if we cannot centralize, we minimize the gaps, we overlap those scan bodies. We want to record the data without scanning the soft tissue first. That's the key. And that also should note, if we're taking the soft tissue, we don't want to record the soft tissue first and transfer that to the implant scan and then add to that with the scan bodies. Because if we do so, we're transferring the error from the soft tissue scan to the implant scan. The implant scan should be done all on its own. So we scan the implant scan bodies completely separate as a separate data set. And we want to avoid the issue that we had with photogrammetry, where those data sets are difficult to combine. And so that's where the common cylinder comes in. It doesn't just add the aspect which means that we've got one library. It means then that the common data set allows us to control the accuracy of the matching of the data. But more important than anything, again, is field control. So when we're capturing the information, again, it doesn't really matter on the system. We need to control what we're doing in terms of the field that's around us when we place those scan bodies. If we try and scan with a really bloody field where the scan bodies get covered in blood, if we try and have the issue, try and scan with that soft tissue get in the way, tongue in the way, lip get in the way, without those retracted, then the scanner isn't going to be able to capture accurately. And so we need to reject if there's any of those issues, and we need to control the field better. So if you're having a problem with bleeding and you're struggling with the scan, there's no point blaming the scanner and the scan body. We need to control the field. You need to make sure that the bleeding stops. Just the same as if we were scanning for an inlay and it was bleeding at the margin, we can't blame the scanner when it's bleeding at the margin. You're the clinician. You need to make sure that that blood is stopped, that we control and we get hemostasis so that the scanner can capture what it can see. So once we've controlled the field, soft tissue, blood, made sure the field is dry, then we can capture super easy. Similarly, if we've got things getting in the way that can cause a fuzzy edge, we need to reject that data. We need to capture really straight, good data. Otherwise, that again will bring in error for the data match later in the CAD. So think of it again in a different way. Instead of getting frustrated if something's taking you a long time to scan, don't blame that process. Think why you're having difficulty in that stage. Go back. Would you take a conventional impression if it was bleeding a lot? You wouldn't. So we need to make sure the success starts before the scanner is switched on in that case. Some people will ask, what is the difference between the SmartX versus non-SmartX? So if we've basically got a Medit scanner versus a non-Medit scanner in capturing the geometry. So what Medit does, it basically does the job of recognizing the whole object during the scan to provide the lab with the perfect cylinder. The geometry of ScanLadder allows you to capture that geometry well anyway. But of course, if you're capturing everything from the get-go right at the start of that centralization, by the nature of the minimal frames and it putting that into position, we're then going to reduce the overall deviation. So it does improve accuracy using SmartX and using a Medit versus not, but it doesn't affect it to the point where you can't use another scanner. So it's important to understand that the real-time recognition can reduce the matching error, but overall, the accuracy and the deviation is still statistically exactly the same as what we'd find with intraoral photogrammetry, extraoral photogrammetry. What we're doing is reducing that error as much as possible in that stage. And we can look at that in a couple of different studies if you want to use that QR code. So this one was looking at the different types of scan ladder versus the Shining Elite intraoral photogrammetry, which still relies on stitching. And then we also have, in comparison to the a lab scan with 120 different scans of implant positions, and then overlaying those and studying the difference in the data. And there's a new one as well that's coming up as well, which is independent and peer reviewed. That's a very nice one to look out for in the coming months, as that'll be comparing all the different systems, and that'll be very interesting. So, Victor Lin, thank you very much. Please look out for his publication coming very soon. But in this study, the main thing was when we overlaid all of those different captures using SmartX, you can see that the precision there is really quite remarkable in that even when you overlay it and look at it zoomed in twice the size of the mouth, you can't actually see the difference in those scans. And so it's very obviously going to be a very nice passive result from that. And that's the data spread itself. So one thing to keep in mind whenever you're looking at any study, including this one, is we want to keep in mind that we're really not looking at the mean. We're looking at the overall data spread. We want to make sure the data is spread in a really confined uh, spread so that the worst case scenario and best case scenario are all well within what would be needed to have a passive result. We don't just want to have a good mean, but then the spread is massive. Because if we think about it a different way, if you go shooting, if the spread is big, then you might have it on target for a couple of those shots, but the spread's big, you're going to miss the target a lot of the time. If the spread is small, then you can be true and you can have a really beautiful spread and you'll be hitting them every time. But you can also be true and precise, in true and precise. So you can have the data spread very confined, but it's just always out. So there's different ways you can look at the accuracy, and it's if you're interested in that, I'd encourage you to go and look at what that difference means in real world scenarios. So going back to the having something to combine data sets. Nice little video here. Let's get the music off, obviously. But that video is really just to show you that even if you keep one tooth, that can give you something as a reference point that can align the data. So we talked about before the alignment of data. So when we're looking at the facial analysis, the importance is that the soft tissue is a separate data set with a separate job. That's for you to be able to use with the lab to have the fitting surface, either as an FP1 where we're keeping the architecture and keeping that the same, in which case obviously it's important because then we need to make sure that it's not over compressing the papilla that we're trying to maintain or even the fake papilla that we generate. Or if it's an FP3, we don't want to over compress the soft tissue. So it's vitally important to have that soft tissue aligned with the implant scan. And I would add to that as well, going back to what we said before, it's incredibly important to have that soft tissue aligned with the pre-op data set well, and also aligned with the face where we've generated and used all those principles Quintus talked about. If we align all of the data sets accurately, then we can maintain what we talked about right at the beginning, the midline, the smile line. We can plan ahead and look at where the end result is going to be. But if we just have implant coordinates and they don't align, then that in and of itself can cause problems with the prosthesis not sitting passively because it's incumbent on the soft tissue, it's putting too much pressure somewhere, or it could be that it's misaligned in terms of the midline or the cant or the occlusion impact that will have. So all of those different data sets are incredibly important to align together. But how do we do that? So remember I said one of the features of ScanLadder is the cylinder to be able to combine data sets. So this little video shows that if you've scanned the soft tissue with these tissue sync markers, The cylinder is exactly the same as the cylinder in the implant scan. And so even if the soft tissue scan is scanned inaccurately, doesn't matter on a small scale with the cross arch deviation, but the soft tissue scanned inaccurately, then combined with the accurately scanned implant scan, those cylinders, even if the soft tissue is wildly different, will combine those two data sets perfectly. So we don't need micron level accuracy in the soft tissue. We just need it to be overall in the correct place and position in relative position to the implant scan and the face. And so we need to make sure the lab has everything ready to be able to carry out what you're paying them for to create the restoration. It can't just be a folder of STLs where they're trying to work out how everything fits together. They need scan files where they understand where the initial start frame was. They understand the pre-op position. They understand the face. They understand at the beginning where they're looking to head to as the preoperative planning and the correct library that they're going to use. And also, we need to understand the platform that you're requesting to use in terms of screws, in terms of whether you're using restorative components like tie bases, or are you going to go direct to multi-unit with a bar? Because all of that will impact the height of the prosthesis and whether they can fit that within the initial planning that you've chosen. So even if you've got a beautifully recorded photogrammetry system, if there's no way of tying that data accurately into something else, then the whole thing can fall apart. And the intent that you've had with the restoration at the beginning gets lost in translation with the lab, and you can end up with problems. Think about this in a very simple way. If we've got the occlusion just ever so slightly out, then that can look great. It might not be noticeable in terms of the midline or the cant or all the things that Quintus talked about, but we might then end up with an interference on excursions that then cause a problem that later becomes a fracture. And so trying to bring in, and really the whole thing I've tried to do again with ScanLadder to give you the ability to match data sets is not just the ability to record the implant scan accurately enough to be passive, but to provide a way to combine data sets more accurately to have a long-term result that's better for the patient in terms of problems with not just passivity, but problems with occlusion, vertical dimension, midline, cant, all of those different things. So make sure you're working with the lab and you understand how all of these data sets are going to be going together so that they can really produce the best restoration that you want. And understand as well that the accuracy from each of these stages can be preserved or erased depending on what manufacturing method you're using and how well that manufactured method is calibrated. So you might record the perfectly accurate implant scan, but if you 3D print on a printer that's not adequately equipped to print accurately with the type of resin that you want, and there is a shrinkage in the curing process, the whole thing won't fit. And you won't know why. And you won't know whether it's the implant scan itself or whether it's the printer that's the problem. Likewise, if we've got a milling machine that's subpar and creates problems because over time there's been burr wear or there's been issues with vibrations because of a loose component, then that in and of itself might cause an issue in the actual CAM manufacturer that we don't understand when we get to the fit of the prosthesis. And so, like always, you get what you pay for, but more really, you need to understand not just the starting position, not just the goal of the end position, but you need to understand where all of these processes are fitting in with the digital workflow that we have, no matter what the technology you're using to record the implant position. So understand that and work with the lab. And if you don't understand one of those components, that's the time to ask questions with your lab, with the people who create whatever thing you're using to record it, whether it's ScanLadder, whether it's photogrammetry, whatever. Ask them how you can use that with the rest of the data. Understand the whole process, not so you're an expert. Nobody's an expert at anything. We're all learning, and these are all tools. but the important thing is to understand where the failures can creep in. So that's when you get to lovely cases which just go straight to plan and fit passively, whether it's 4, 6, or more implants. And the final one I'm going to leave you with, just a basically box ticking exercise that you can use as a clinician if you've got your scan. Most failures, no matter whether this is a restorative scan or whether this is an implant scan, most failures are visible before you even export to the lab. Quite honestly, I see some questions sometimes. Um, I really wish this would be taught more at a more basic level, because the reality is that a lot of problems can be picked up right at the start. People have problems with the fit of things because they've not captured margins. They've captured where there's a bloody field. There's been movement in a 3D face scan or a photo. There's been, movement during the scan. There's been interferences. Tissue interferences are a big problem. People think things don't fit sometimes when actually it's the soft tissue or even the multi-unit selection that they've chosen the wrong height. And so it's putting pressure on the soft tissue and stopping it from seating. The wrong screw can sometimes come into things where people have tried to use a screw within a scan body that's different, or a screw within a restoration that they've not coordinated with the lab properly. And little things like, using the scanner with, smudge screens, smudge lenses, all of those basics really need to iron out before you get down to, worrying about whether one component is a failure. You need to look at where the issues come in and deal with that. Just the same as before, I was saying look after the field, and the scanner will look after itself. So pick up on all of these things and you'll do well. If the mesh looks plausible, but the field is uncontrolled, listen, you trust the field. The field is showing you that it's not going to be good. So make sure you're looking after yourself so you don't stress about it, and take your time, control the field, and make your life easier, scan easier. Okay. And the end result for the patient should be one that takes all of those principles into account with the facial analysis, so that no matter what you're doing, all of those end up coming to a really nice fruition when you put a lot of effort in with Filage, because it's difficult and there's a lot of surgery involved. The patient has to go through a lot. And there is nothing more frustrating when you've got a bloody field than trying to scan when that's causing an issue. When you're trying to put the prosthesis in and something doesn't fit, you don't want that. So controlling all of those different aspects, making life easier, is going to take away a lot of those headaches. And that's basically it from me today. And I think that's it from Q as well. So thank you very much, guys.
Well, thank you. Thank you for an excellent presentation, Quintus and Adam. I think the message for the day is accurate data, whether we are digitally planning or designing or fabricating. I think our data sets play a very important role in delivering what we want as a predictable outcome at the end of it. Uh, we'd request participants, if they have queries, to post them in the chat box. So far, we only have one address to Quintus, which is saying, hi, Quintus, beautiful pink and white aesthetic result. Can you tell us about the workflow with the patient?
Oh,
Lin-
yes. Yeah, I see the question. So from data collection, I basically do a mock-up, and that we 3D print, and depending on how difficult the case is. So if you think about it, you'll get your best results from patients that have got the best alignments. And if there's rotations and things like that in the teeth, the gingival architecture is not going to be great. You need to ideally get a patient to finish with either aligners or ortho if they have those, and then do your veneers or crowns or whatever it is that you do. But for me, I do a mock-up first. We 3D print that. And then, depending on, for me personally, how difficult I think the case is going to be, I would transfer the mock-up either into the mouth, or we, with a stent that we make from the 3D print, or we will 3D print the mock-up directly and put it in the mouth. And then from there, I use mostly either ExoCAD, depending on the library that we've used for the mockup, or if it's a straightforward case, I'll use Serec, and then we mill it that once we've done the preps, we would scan that in, make sure our data sets align, and then we will design it and then mill it and finish it on the same day in-house, no technician involved.
Okay, great. Quintus, a small point of discussion here. I know it's a huge, big topic, but any hints on how one could decide on whether to go in with an FP1, FP2, or an FP3 when you're designing the case?
I think, like we looked at, it depends on it's a difficult one because it's quite wide, isn't it? It depends on the amount of soft tissue that you have and on the patient's smile line. So, um, and Adam is also good to answer this one because we see a lot of, especially in America, the guys are really keen to do, big bone reductions and everything so that they can redesign the the gingiva and make sure that everything looks aesthetically perfect. It's I think it depends on the patient's smile lines, lip thickness as well. You know how much they're going to show, and then also the amount of soft tissue and things you're going to have available. I think personally, if it was me, I would try and protect as much of the vertical bone as possible. Um, and not go in and do bone reductions and everything so that you can do a full prosthesis with gums. But it depends on case by case. Depends on the the thickness of your gingiva and whatever you're going to have left after the surgery. But I think mostly I would try and be as conservative as possible.
I
Okay.
agree. I think from my perspective, Bosun, I think in terms of FP1 versus FP3, I never like an FP3 simply because I don't like fake gum. I never really find it perfect, or at least as perfect as I'd like. And there are some really excellent technicians I've seen do some beautiful gum work and re just really quite astounding. But not everybody can do that, and not everybody can have that as an option for the patient. But I think the biggest and probably the easiest way to distinguish between what I would see as doing an FP1 or FP3, some people go down the road of if they can see the gum on the smile, then they'll trim it back and do an FP3. I don't think like that. So for me, if I can see gum, that's actually a good way for me to do an FP1 because I just need to manipulate that to look like, I manipulate to create architecture to be able to create papilla. So from my perspective, an excess of gum, really the determining factor is whether that's symmetrical or not. So if the FP1, if there's enough gum there, that I can manipulate the architecture to look like there will be teeth emerging from gum, I will make that extra effort because I think it'll look better for everybody. But if there's an asymmetry there, so say for example, someone who has maybe a 1 to 4 bridge or 1 to 3 bridge and the gum has really gone up quite a lot, or they've been wearing a partial denture, then realistically, it's going to be very difficult to try and bring something back to an FP1 in that. And then that's a very obvious FP3 that we need to then flatten everything out for hygiene purposes. So it's really for me more about trying to think of the best interest of the patient in terms of what their appearance is and what the overall hygiene is going to be for the patient. I saw a point by Roller there, saying for FP1 with about 10 millimeter interclusal space, do you prefer titanium reinforced zirconia or monolithic zirconia? Um,
There's not a one answer fits all for this,
Yeah,
is
that's
there?
right.
it's really not because I'm going to get criticized one way or another with all these answers. Um, I've tried every which way over the past 14 years in doing full arch. I my, my first implant case was supposed to be a nice single tooth in 2011, and the patient cancelled on me, and then the second one cancelled on me. Not for anything bad, just that their routine just didn't fit in. And then one I was planning on a few months down the line was a full arch all on six, and that came in first. She had so much bone, and she she probably had limited space, and we should have really probably done trimmed it down to an FP3, but we did an FP1, and that was at the time with an acrylic wrap, and it lasted so long. It was like 10 years with that with a nice acrylic wrap. It's all analog, all with separated verification jig and everything done the right way. But then, and with guided surgery and yeah, crazy first case. But then later on down the line, as she got older, the healing, the reason why I'm giving you this tale, because I always like to tell tales, but the real world. So her bone shrunk a little bit over time, as she got a little bit older and she got a little bit frailer. And my old, my previous practice, Hudson, he ended up doing the restoration. Implants were still fine. They were all tissue level Straumann's that, nearly 15 years later, she was still rocking with them. Everything was good, and he was restoring them again. I think because everything had shrunk a little bit, then it was a little bit more difficult to go back to that. But she wanted another FP1. But to answer the question, because that was kind of limited, I think it's more determined by the occlusion in that scenario. From her perspective, it worked well because she was, a lady that, didn't have a hard bite, and an acrylic wrap just worked nicely. If I go down the road of a pure monolithic zirconia, I need to know damn sure that the occlusion isn't going to be an issue for that. If I go down the road of an FP, one and try and reinforce it, you've got another issue. You've got a thinner zirconia. It's over the top of the metal bar. So you've got to make sure that the zirconia is well bonded to the framework, which is difficult. It's got to be well sandblasted. And don't trust anyone that says, "Oh, you can just bond it." You can't. You need to make sure there's actual mechanical hold there. But both ways and really every way with full arch, the hard thing is that nothing is simple and clear cut. And the biggest factor in all of these cases, whether it's FP1 or FP3, comes more into, I think, what the previous state of the occlusion was like. And I think I'm more probably inclined for someone with a few discussions we've had recently with wanting an FP1, I really wanted to go down the road of a reinforced PMMA on a sleeve with titanium because it's repairable and it wears a little bit nicer. But the end result of the conversation that we had with this, it was a difficult patient, there was a lot of wear, was that perhaps Phil Reddington's approach, the BDT approach with a thimble bar, individual zirconia teeth, and a wrap of the gum, or even if there's no gum, if it's just a thimble bar with individual zirconia teeth, allows you to have the benefit of the thickness of the zirconia better and individual teeth to be able to replace if they break something. Because with all of these cases, and this is why it's a difficult thing to answer with any of these, from my eyes at least, is that the end goal really isn't about restoring the smile, restoring the gum, restoring the teeth. That's obviously part of it. But it's have given them something that is replacing what God gave them that failed, that you want to last a long time because they're paying a lot for it. And so, the importance of the accuracy of all those stages, and to bring it back to the lecture, from my eyes, really was out of necessity trying to minimize the error in all of those things, because then the last thing you're dealing with is the patient and their effects on whatever you use and whatever you create. I think whether, to answer your question more directly, Roller, with whether I use reinforced zirconia with a metal bar or monolithic zirconia, I think it's down to preference. I think screw is down to which screw to use is down to preference. I think you can go down all of these roads and you'll probably be affected by the patient in exactly the same way. You'll probably just curse yourself you didn't do something different, but actually you couldn't have changed anything. It's just the patient. So whether they keep good hygiene, whether there's, issues with parafunction, all of that is more individual to the patient. And so it's a very long-winded answer, but it's always also a very complex scenario for large. And so I think if I was to summarize that with everything, it's just to minimize the error as much as possible, protect as much as you can with a night guard, and in the cases where it's really demanding, then separate things out as much as possible in terms of either individual teeth or some kind of you know structure that will wear. But that's my experience
Yeah, I think there's a
personally.
second part to Rola's question where he's mentioned two segment prosthesis. So I think that also gives us a clue that it depends on the implant positions. If you have a lot of distance inter-implant distance, and you're going
Yeah.
to hamper the zirconia over there, which has got a lot of pontic space there, I think it would be better to reinforce as compared to just zirconia. And like you said, Adam, occlusion, I think, plays an important role. Plus, what is there in the opposing arch, whether you have zirconia restorations, you have PFMs, or you have natural teeth or denture teeth, it'll all make a difference. Okay, I
Yeah.
think we have one more from Stephen. How do you deal with a case which patient came with canting occlusion that needs rehabilitation on a single arch? How to deal with this problem while designing it?
Q.
I
You've got a good
assume
one
this
with this
is,
one.
Yeah.
I assume, Stephen, is this on existing teeth rather than on full arch? Uh, so say you have a full, full set of teeth and you've got a canted occlusion. I'm going to assume that that is the question. Yeah. So, okay. So if we do that, so what you need to do is you need to deal with the occlusion first. Um, Now, that is by either analyzing the actual jaw movement and use something like mod jaw. Depends on how deep you want to go down this rabbit hole because occlusion is the most difficult thing to get right. And I always say occlusion is only a problem when when it's a problem. So some patients can tolerate a lot without having any problems, and other patients cannot tolerate the slightest change with massive problems. So um, in cases with the canting occlusion, you can firstly look at ortho, fixing it with orthodontics, make sure that your occlusion is correct, and if the cant can be fixed that way. If not, then I will deal with the occlusion restoratively by either using something like modjaw that we know what the patient specific motion is, and then designing firstly on the posterior something that will correct that for me so that we can protect the anteriors on a cant. And then use like a long-standing provisional or what Adam and I call it prototyping. You use 3D printed permanent materials to design the ideal occlusion and let the patient walk around with that for a few months and see if you've got failures in the occlusion. And if that all works, then you go and you restore it to the new occlusion that you've determined with your new design. If you have problems while that is happening, then if you haven't really done anything that's irreversible, you can remove it all and just say to the patient, there's not much we can do. You need to have ortho first. So I would say that would be the way I would look at that. If at any stage during the prototyping you have really serious problems, then you know it's maybe a case that needs to go to a specialist, or you need to just stop there and say we cannot achieve what you want unless, say, we do ortho first, or you see a specialist. That would be my advice. So with all of those cases, I'm normally quite careful first. And I tend to err on the side of caution where we do things that are not necessarily irreversible first and just get the occlusion stable, get the patient stable. And if that is working fine, then we go to the next stage where we start restoring.
I think as well, it's important to add, Q, that it's a very, without stressing it enough, it's a very complex subject, occlusion. A very good book you can pick up if you look up Riaz Yar. I think he's on his third edition now, Q.
Mm.
But he's just brought out a new book on rehabilitation with the full arch. And in terms of just a general user, I'm not talking about doing specialist things, but in terms of a general user, I am always in favor of trying to be conformative because if it works for the patient, then that's the ideal we want to reproduce. If we're then obviously changing the occlusion in some way. But one of the nicest things about digital is we don't need to change everything to conform. And what I mean by that is if you imagine the full arch and if we're keeping the pre-op situation of the conformative occlusion that works for the patient in terms of their the lateral excursions, all of the different 3D movements of the mouth, the stops, all of those things, you can reproduce that, but just change and camouflage the anteriors, and you can change the way they look without really changing everything. Obviously, if you're going to, and if you have the experience and education and knowledge enough to not go down the conformative route and rehabilitate the patient, then that's a different question where you need to take on board different principles, but that's obviously a lot deeper conversation. And thoughts change on that all the time. But more importantly, you then have to involve whether there's any parafunction and things like that, because if you think about it in a very simplistic way, if you're changing their whole bite but keeping the opposing arch the same, then they're going to be heavier on one side. So, or you're shortening one side tremendously. What are you then going to be doing with where all the curves sit, where the teeth and sit and rest against each other, moving around the mouth. So, um, as I said, I'm always in favor of keeping conformative. And if you do make adjustments, keep in mind that one really nice way of doing any restoration, but particularly implant restorations that we talk about with ScanLadder, whether it's a 3 unit, 4 unit, or full arch, if that provisional goes in, the prototype, what Quintus was saying, if there's adjustments that we check on, excursions, whether we're using something like Modular or whatever, once we made those adjustments, it's very, very nice and easy to just rescan that, send that data to the lab of just that scan, and then the lab can bring that into the CAD design and virtually grind out where those high spots are. So it doesn't matter whether it's a single restoration or a full mouth, you can do that easily. And so that's to me where 3D printing comes in to really help us if we're doing all of these things, because that's what it's there as like a full prototype verification. And this kind of answers the question someone's asked about a verification jig. Do I do a verification jig? And the answer is always, but I'm not doing it for ScanLadder. If you use ScanLadder in the correct way and you position them in the correct way and you get a good scan, if you control your field, it will work. I've got 3,000 users across the world using it. Um, Anybody, if I can count on two hands, if I have somebody who's maybe three hands who've come up to me in the last few months have said, I couldn't get this to work for this. And we nail down the reason for that. We correct the problem of that. They speak to us on support. There's always a reason, and there's something that they're not doing, whether that be transferring from soft tissue, whether that be trying to centralize, but actually they're just spacing things out. It's a big arch, whether they're not overlapping things, whether they're not controlling the bloody field. Those things are separate, and those things would apply no matter what you use, or whether you're even taking an analog impression. So, from my perspective, if you're doing things right, you don't need a verification jig for ScanLab to work. But what I do is verify the position of the teeth, verify the occlusion, verify the way that they look, the teeth shape, as well as the position of the implant. So if I've got all of that information in that 3D printed provisional prototype, then when I try that on, like I said, I can trim out, adjust any of those points to be able to then just very quickly and easily virtually grind in, or your lab can virtually grind in those points, and we end up with a really accurate result that not only fits but also has those the little bits dialed in. Um, Over time, have I changed anything in terms of my approach with that? And a good thing to answer is really what I said before about Ashton is what he's picked up with doing probably well over 100, 200 scan ladder cases now with people all over the place is from his perspective, the he would always recommend taking a new scan once the integration is completed simply because of potential micron movement over that 3 6 month period where if you depending on obviously whether you've had a prosthesis in place or not but just to make sure that everything is in the same place and which isn't necessarily to do with the recording of the initial position, but it's more the how things have changed in terms of the patient and the way that things are at that time. um, that kind of again relates to, do you think monolithic zirconia is a good solution with interclusal space between 10 to 15 maximum? Listen, Ali, realistically, I don't think anything's perfect. I know a lot of people who just use monolithic all the time and do it for all the right reasons. They'll use different screws. I think with full monolithic, people seem to prefer power ball and desk screws from everything I've seen. I think the Vortex and Rosen screws people tend to prefer for more provisionals like PMMA or 3D printed provisionals. But in terms of monolithic zirconia, I don't think people are really caring whether it's 10 to 15 millimeters maximum. It's more the fact that they just do everything monolithic zirconia. But I've seen people do everything and it works. I've seen people do everything and it doesn't work. And like I said, I think that's more to do with the patient and what caused things to fail in the first place. Obviously, forgetting about what we're talking about before with controlling the field and passivity and that sort of thing.
I think there's one more question, Adam. Just to wrap up your what you just mentioned, I think your prototype with using the tie basis would be a good verification jig as well as an aesthetic check and a functional check that you can do in the patient. So I think that's a combination that we can do. There's
Mhm.
one more question from Michael who's asking about the jaw tracking moments which sorry, the SmartX workflow in Medit has along with the scan ladder. So,
Yeah, so it's a good question because a lot of people get confused about the workflow in SmartX because it seems almost backwards sometimes with the thought process of doing the implant scan first, then the soft tissue, and then the prosthesis. Because some people will think, oh, well, I've got a pre-op in place, I want to scan that first. So why is that later? Likewise, they might think, oh, I want to scan the soft tissue first. The reason why it's that workflow and that way around is mainly so that people don't use the soft tissue, which has error in it. That's the whole reason why we're doing all of these things, and transfer that to the implant scan and add to it with the scan ladders. Because then it doesn't matter about how good the scan ladders are. It's got the error in the cross arch deviation from the soft tissue scan. And so we're really just adding to erroneous data rather than something new. So the workflow is positioned that way to make sure people more likely than not are going to do that. But it doesn't stop you. You can do it in any order you want. You can just click through. So you can, if you've got a pre-op, you can go to that first. If you want to do the soft tissue, do that first. But one thing I wouldn't do is transfer the data from the soft tissue. So from my perspective, I like that workflow simply because I'll put the implant scan in first. That will make sure that I've got that as accurate as possible. The soft tissue, the idea of tissue sync is if those cylinders are swapped out and from the implant scan, the software automatically deletes the those implant scan bodies And as long as there's enough left, you can scan the soft tissue by replacing the bits that are cut out or scan with this tissue sinks or whatever you want to do. But realistically, even if you separately later on, you know, you do all of your scan ladder stuff with the SmartX in one stage, the soft tissue changes after 3 months, it drops and heals back, so you unscrew. You could just take a soft tissue scan with the tissue sink there, and the lab will be able to match those cylinders to the implant scan, even if it's a completely different scan or even a different scanner, it doesn't matter. The whole point is those cylinders are the same, so the software will match them together. It gives it points of reference. That's the key.
I think the question was more to do with the jaw tracking movement,
Yeah,
So this,
the occlusal movement
the
scan.
occlusal movement scan. Yeah.
yeah. So you can still do all of those things, but you do that later when you've got the provisional in place, or do it separately and record that data with the provisional. It doesn't really matter. It don't get too worked up on which way round the workflow is. Don't get worked up whether it's separate cases. It really doesn't matter as long as there are common features to be able to match those data sets. Then you can bring in data from wherever. I mean, think about it a different way. With Modjaw, you're bringing in data from a scanner, and you've got really accurate data movement. So, sorry, 3D movement from the patient. You've got that data that aligns with a calibrated position of where things are. So it's it's not about the workflow. It's about the data and where the reference points are.
I think I will just add to Michael's question there. So he says does the lab know how to use those movements records? I've never had luck
Maybe.
always adjusting at chair side. Michael, I would say check with your lab that they are actually putting that data into the design. So, say for example, if you're using an Exocad, to me is the only software really at the moment that is good enough to use with that. Um, if they are bringing that data in, it should have that incorporated in when they do the dynamic occlusion bit on the design bit. If they are not bringing it in, they can still use any sort of articulator and then create a simulated movement that should better account for the occlusion. But if you are sending that data to them, check that they are bringing it in because I know there are a lot of labs that don't do it, although you send them the data.
I'll tell you
Um,
what, to add to that queue as well, something which a really important point, and we're going to come back to this in upcoming things, Berzin. So this kind of relates, but something that's really important for anybody, anywhere in the world, the current state of things anyway, to take into account. Some places have great lab techs that do great digital designs internationally. I mean, there's some really gifted CAD designers out there, and I don't want to take away from those people, you know, Ashton, people like that. But there's a big problem, especially in the UK, where labs have, in some respects, de-skilled themselves by outsourcing in probably the fear of where digital was heading and in the fear of CAD/CAM with CEREC and all those sorts of things years ago. So there's a lot of outsourcing of CAD design and there's a lot of outsourcing of even manufacture. I don't know how much that impacts the rest of the world. We have a real problem in the UK with trying to get new lab techs trained. There's really not that many places, and it's really sad. And I think the US is the same. It's a dying profession, which is really, really sad. Because there's some, like I said, really skilled lab techs. The reason why I say all that is with your question very specifically, Michael, that you might be using a lab that you don't know whether they're actually doing the CAD design or whether they're outsourcing to the Philippines or China and communicating between you and passing, the 3D data of whichever source of communicating the source of wherever you've captured jaw movements. You don't know whether that's actually being used if they're not using the data themselves and they're outsourcing. So I think it's always worth, if you're doing complex things, having an honest and candid conversation with your lab these days to check whether they're actually doing the work which you're communicating them with the intention of saying, oh, can you bring this into the design and stuff like that. If they're not doing it and they're basically just finishing the manufacture, finishing the CAD, the CAM, whatever it is, whether they're doing the staining and glazing and layering, it doesn't really matter. I mean, they could do beautiful work. And I don't say it to take away from them, but more that you need to know what exactly is going on in that workflow. Just the same as where I was saying controlling the field. You need to know what's happening with the restoration. If you pass into the lab, who's doing it? Because it's that person you want to speak to. You want to know, or at least make sure that they're using it. Because, like Quinn said, they just
Yeah.
might not bother.
And I mean, there are a lot of other issues as well that can influence the occlusion, especially in mold restorations. And the biggest one that we see commonly is that there's not enough occlusal reduction for the minimal thickness of the material and to allow enough reduction in the occlusal surface of the restoration. So if you are doing everything from your point correctly, give the lab a great prep, give them enough occlusal reduction, then there should be no reason why you should be, when you are fitting your restorations, that you are having to reduce and adjusting chairside. Um, from in my practice, the lucky thing that I have is I have all of the toys and the gadgets I can, and I produce all of the restorations myself. But it has taken time to know what the limits of the milling units are, and also how much occlusal space you need to give them. So what Adam was saying is very correct. Have a open and honest conversation with them and say that, listen, do you have enough occlusal space? Are my preps good enough? Do I need to up my game on that? Because obviously, the better prep you give them, the better they're going to be able to design and the better the aesthetics will be at the end. So if there's not enough occlusal reduction, there's not much that they can do because they still need to produce a restoration for you that falls inside the parameters of the manufacturer. Say, for example, if you're doing an Emax crown and you're working on CEREC, it will have certain parameters included in minimal thickness that you can override, but you take the responsibility if you're doing it yourself. But as a lab, they're not going to override those because they still need to give you a guarantee on the restoration, and the restoration needs to be that thickness in order to qualify for the guarantee. So that's where that is very important. But if you are doing those things correctly and you're still having to grind in, then I would say the probability is that they are not using all of the data that you are giving them, or when they are doing the staining and glazing, that they are adding a lot of thickness with the stain and the glaze on top of the restoration. That can also cause that as well. So there's a few things that I would look at, but the main thing is just have that conversation with them and just say, um, is the problem on my side or is it on your side? What is your actual workflow that you use for designing these? And if they are exporting, which I would say in the UK, probably 85 or 90% of labs are doing at the moment. They are outsourcing everything to outside labs because it's just not financially worth it for them to spend a few hours on a crown.
Yeah, it's really sad. And I think probably one way to answer all the questions we've had so far, and labs, um, you know, they won't like it in some respects with AI, with the advances that it's got, but I my gut is that AI is going to solve and answer all of these questions so that you can be the best clinician, the lab can be the best technician, that the clinician can understand what the best outcome should be and what the best method should be for all of these questions, whether they should go down the road of an FP1, FP3. And I'm not suggesting letting an AI make decisions, but more understanding in that specific scenario the risks that are involved, and the precautions you'll need to take, and also in terms of decision-making trees, which when we should analyze more, something which we might not have picked up. And I think in terms of the lab, what that will mean is that what they make will become more predictable. And I think in the long term, the ideal scenario would be that the clinician and the technician work together so that AI doesn't replace either. It's augmenting the relationship to the point where they're both backed up by data and analysis in a better way. So that's I think the way then the next 5 years are going to head anyway, especially with things, like the 3D smile analysis we've got now, some of the AI generation. They still need somebody to tweak things a little bit. They still need a good lab tech to do the design. And hopefully if we can get more in-house familiarity with CAD design, then whatever the AI does, then that can sort of regenerate that clinician lab relationship. What I would like anyway.
Yeah, I think that summarizes the entire discussion. Just to add on to this, what Michael's point, I think what Medit gives us is more of a video recording of the excursive movements and not the exact measurements. So it gives the lab a data set to go by as to how much of clearance there is or what is the inter-art space, etc., in the excursive movements. But when you look at devices like the Mod Jaw or the Meti Smile Jaw tracking, that gives you exact analysis of related to the TMJ and the facial analysis. So I
Yeah.
think it's all about gathering more data sets, putting it all together, and making all the systems speak to each other. So,
Yeah.
of course, it would need
And
a
something
very,
you guys as well, we didn't even talk about Berzin, but something which you guys around the world will have that we don't have in the UK is the ability to use larger CBCT scans, which go right up to the condyle. So you've got the actual patient's face bow to be able to
yeah.
use in your 3D analysis to combine with the face and be able to set up the perfect virtual articulator in XCAD. We don't have that, so I can't tell you about it as much as I'd like to.
Yeah, so we kind of use it for our FMR cases where we need to exactly analyze the final position and we need the
Yeah.
condyle positions.
Lucky
Great.
you.
So thank
All
you
right,
very
man.
much once again, Adam and Quintus. Would you like to brief us on the MSc program, Adam, a little bit something about it so that our viewers
Yeah, sure.
know?
So for many of you who know, Berzin is one of the faculties that is running over there, and basically, what we've tried to build with the MSc in digital dentistry is really the world's biggest collaborative approach to digital dentistry education. We've got a few really exciting additions to the online platform. That what it is a way for users across the world to get on board with education in terms of understanding all of these principles in more detail because we can't cover everything in one or two lectures or YouTube, and it does take extra reading, it does take a lot of foundation lectures, and building all of that through a series of online lectures, online tutorials, online examinations, and that's the core component that we provide from the IDDA. Then there's the hands-on component, which is the other third of the MSc as a whole, where the faculties around the world, including Berzin, will provide the hands-on education. And then the final part is the students part, where they'll do the university components with the research modules, with understanding of the how they're going to go about doing their own dissertation, and you can do that on whatever you want. So going down and doing your own research, if that takes your fancy, is becoming a master literally in understanding the principles, the workflow, practicing it hands-on wherever you are, and you've been able to visit a faculty member, and all of that's open. So if you want to go to one of the faculties to have that study in that country, even if it's just a preference, you can. So you'll probably have people from all around Berzin visiting because you like to have some beautiful locations for your events, huh?
Yes.
So Yeah, if anywhere around India, you can get in touch with Berzin with that side of things, and we've got more of that launching later this year. Next year, we've got a few exciting parts of the online platform, but as always, the IDDA community is a beautiful one. We've got really nice, great students from all around the world that help each other on a 24/7 basis. That's kind of migrated a little bit to WhatsApp in some ways, but you know, everybody works together, and it's a beautiful thing because it's a journey that everybody's on. We're all learning together.
Yeah, I think it's great to have this forum where we can communicate with each other, share our experiences, and learn from each other.
Yeah.
So great. Thank you very much once again. And thank you for being a part of the EdTech webinar series of the Digital Dental Forum. See you again
Thank you.
soon. Ciao.
Thanks,
See you
guys.
guys.
Thank
If you
you.
have any other questions, we didn't say you can always send over an email or pop on the different forums. You're always welcome. Okay.
Yeah, we
Okay.
we we are going to be live on Facebook as well, and we will continue to keep posting this video on Facebook as well. So follow us, and you will be there. Thank you.
Perfect.
Thank,
Thank you
thank you,
guys. Have a good
everyone.
weekend. See you later.